Welcome to the D4A Personal Injury Show. I'm your host, Jean-Paul Anderson, and I'm here with my co-host, Nicole Anderson.
Hi guys, how are you today?
All right, so today we're going to be interviewing an orthopedic spine surgeon on what's called ADR, artificial disc replacement. And basically, what are the steps to getting an ADR procedure?
Awesome. Thank you, JP, for talking about ADR. I want to welcome our guest today, which is Dr. Alexander Ghasem. He is an orthopedic spine surgeon. So welcome to the show today.
Thanks. I'm excited to be here, guys. Thanks for having me.
Awesome. Yeah, we look forward to having you here today.
There's a lot of general public questions, a lot of law firm questions on spine procedures that a lot of people are interested in. So we're going to go through a few of those questions today.
That's right.
I'm going to have JP start.
So I'm going to be starting for some reason today. Let's see.
You're the lucky one.
So I guess, after all else fails, we had a pain management doctor here a couple weeks back kind of explain like procedures and epidurals and when it's proper to do epidurals and stuff. But what happens after that fails? What are the suggestions? What type of, what are the steps to somebody being recommended for orthopedic spine surgery?
Yeah, that's a great question. Just like orthopedics in general, orthopedic spine surgery, for the most part, is a quality of life issue. So it basically comes down to when symptoms of nerve compression or of the spine itself are actually affecting your daily life in a way that you can't basically manage anymore. And you're saying, I'd rather, try another alternative treatment. And surgery, we usually reserve that as the last option in a lot of cases, unless you're dealing with more of an emergent situation, and we can get into that later as well. But that's in general, how we kind of evaluate patients for surgery.
Is there a certain amount of procedures you have to do? So say, for instance, so much physical therapy, so much chiropractic therapy, so many epidurals before you're like, okay, this is what we need to do now. Is there kind of like a range between those, or it's just like none of it's working and you need surgery?
That's a great question. I think a lot of times the patients will self-declare. They'll basically come in and say, either therapy's made me worse or I did an injection and things are just not going well. Usually I say, you'll tell me when you're ready for surgery a lot of times, as far as that goes.
And when would you say spine surgery is like an emergency, like someone needs it really, really bad?
Absolutely. We have a couple of conditions. One's called myelopathy, which means that you have spinal cord compression, and that results in a host of symptoms. And if you have kind of quick neurologic decline following imaging findings that are consistent with myelopathy or spinal cord compression, that's an acute indication or emergency for spine surgery to proceed. So when we see people who are getting rapidly weak over a short span of time, at that time, if there's an imaging finding that correlates with that, then we'll say, hey, we need to move very quickly so you don't basically lose that function permanently. And then on the other side, in the lumbar spine, we have something called cauda equina syndrome is another example. Again, with that neurologic decline pattern or paradigm following, people will start to lose bowel or bladder function very acutely. And again, if we don't act quickly, those are things that can be permanently lost and cannot be regained. So we have to act very quickly, and that becomes an emergency for us.
Okay, so a couple things to kind of explain to general public would be, so if you have like numbness in your legs, if you lose bowel functions, yeah.
Absolutely, yeah. So people who oftentimes are going to be candidates for surgery, and especially when I recommend, when lawyers ask me, hey, how do I know that a patient is probably going to be an operative candidate just by talking to them? I say it's really easy. There's oftentimes if a patient is complaining of radiating numbness or tingling or weakness either into the arms or the legs, there's a pretty high chance that if they have imaging findings on their MRI scans, that they're going to be a likely candidate for surgery. There are a few exceptions where if you just have mechanical or axial back pain or neck pain in the setting of instability or failed conservative treatment, that we consider you for surgery. But in general, if you're having signs of nerve compression, or like we talked about myelopathy, where you're hyperreflexive, or your hand coordination or your balance is off, all of these things can be findings that are associated with spinal cord compression and can make you a potential candidate for surgery.
Okay.
That's very interesting. My goodness. I guess okay, so how would you explain a fusion surgery versus a ADR surgery?
That's a great question. A fusion surgery is basically an operation where we work to immobilize the spine. We use either the body's own restraints, or we use instrumentation with screws, interbody spacer devices to hold those levels in place, and then your body takes care of the rest. We actually form bone, but in order to do that, the body likes to create bone in areas where there's not significant motion. And on the flip side of that, artificial disc replacements are really what we call motion sparing devices. We want to preserve that motion for those patients, and so they actually in a lot of ways are different in their goal, in their end goal.
Got it. Wow.
Is there a difference between like say for instance with age and bone loss? So say for instance you have a very young candidate who's in their late 20s, then you have someone who's elderly in their 80s-ish, 70s. Because of bone loss with age, are they candidates for different procedures? So say for instance the disc replacement goes into the vertebrae of the spine. Do they have enough bone mass to hold on to that, or would they be a fusion candidate?
That's a great question. What I like to tell my patients, because a lot of our patients are on the elderly side anyway, that age is just a number. And I tell my girlfriend that as well. But in general, I would say that there's a couple factors that play into that. On the younger patient side, we usually as a specialty try to avoid fusions, specifically for adjacent segment disease. We know that, as one level fuses, some of the adjacent levels will start to break down a little bit faster. And there's some controversy, particularly in the cervical spine, about that. But we try to do kind of one and done surgeries. And that's not to say that cervical disc or lumbar disc replacements will last them their whole lives. But we try to prevent them from having multiple surgeries that are potentially avoidable.
In the future.
Exactly. And so on the elderly side, a lot of times those patients have a lot of degenerative findings by nature. Just by living life, you end up wearing down a lot of your joints, and some of those things end up precluding you from being a candidate for artificial disc replacement in general. So in general, our older patients will end up needing fusions, and sometimes our young patients end up needing fusions as well. It just really depends on the pathology. And on the flip side of that, I've also done cervical disc replacements on people in their 70s and 80s. It really just depends on the patient-specific criteria as far as that goes.
Is there any way to really describe, I don't know if we can show pictures during this video, but to describe what an actual artificial disc replacement looks like is pretty cool, actually. Some are
we just saw
just
one,
slipped in, and then some are kind of like magnets that it's like a heavy duty magnet, right, with like a little saucer disc that kind of goes.
Yeah, the way they
it's like a little UFO disc that just pops in. It's pretty cool.
That was very well scientifically articulated. That was great. That was
UFO.
Great. It's actually amazing. I mean, they're all motion sparing devices. But even between the companies, there's so much biomechanical difference in the way that they're designed. Some of them are metal on metal. You have some that are, have a polyethylene core. There's some that come in modular pieces that you assemble within the patient. Some of them are already pre-assembled. Some of them you just, like you said, kind of plop them in like a UFO. And some of them you have to create predetermined tracks or keel tracks that then the final implant will then rest and fit into the actual vertebrae, and then serve as an artificial disc to retain motion.
Since every body is built differently, is there like a shoe size measuring kit that you do before doing one of these surgeries? Because everybody's disc is different sized. Is there any way to kind of pre-measure that and know what type of shoe you purchase before you pop it in?
That's a great analogy. Yes. So we do take some measurements looking at the height of the disc, and we look at normal discs in the same region of the body, because everybody's a little bit different, and we measure those on some of their preoperative scans for patients. But then we actually make a lot of intraoperative assessments too. So we actually, when we're doing the surgery, we have several trials before we actually pick which shoe fits the best. And so what we'll do is we'll insert the trials, we look at them just visually, and then also under x-ray and sometimes intraoperative CT scans, and we'll make the best assessment based on the best fit for the patient at that time.
Awesome.
Interesting.
Yeah.
And I guess, I mean, that all seems really, really interesting. And how long does it take to get something like this done? And what are like the actual, steps from the last evaluation? Like, does a nurse call you and ask you, questions before the procedure to make sure that your health is right? Like, what are the exact, steps before the surgery?
Yeah. I think that's a great point, in that a lot of people think that the surgery is just that the surgeon shows up, we show up the day of surgery with this person, and we do this 1 hour operation, and then we walk out of the room, and that's really it. But there's so much that goes on behind the scenes, not only with the surgeon and the patient, but the supporting staff, the hospital, the surgery centers. Everybody's basically coordinating a symphony to make sure that that patient is well optimized and ready to go for the surgery, and that everything goes according to plan as far as that goes. So from the last time I see the patient, I want to make sure I send them to their primary care doctor to make sure that their health is in line. We go over the trajectory of the procedure, what it's going to look like right after surgery, what it's going to look like in 6 weeks, 3 months, 6 months, a year, and so on, what they can expect, what are potential complications. And then I recommend that they go home, read a bunch about the procedure. I send them videos from my own website to review. And then once that's done, I have to coordinate with several other supporting casts that are in the operating room as well. So we bring our implant experts in from the manufacturing side. We have people in the operating room who focus on nerve monitoring and basically making sure that during the surgery we have a keen understanding of what's happening to the patient, so that we're not causing any neurologic injury during the operation as well. And then the anesthesiologist also will evaluate them preoperatively. And then at that point, we kind of move forward with our planned operation.
How long is a recovery for something like this? Is there physical therapy or pain management treatment that you need afterwards? And how long does that normally go for before they're okay without any kind of medications or physical therapy anymore?
Are you talking about the artificial disc or the fusion operation?
Both. Let's talk about, so artificial first.
Okay. Yes, the recoveries are very different for both of these procedures. So for artificial disc replacements, and actually the approach, the anatomical approach is the same for both procedures.
Okay.
So the pain recovery initially post-operatively is actually very, very similar. And because you're doing a muscle sparing approach, you basically cut through zero muscle in both of these operations. And so people recover very quickly. I will give them some pain medications to go home with after the operation. And what ends up invariably happening is they come back to my office and they throw the pill bottle back at me, and it's completely full, and they say, I didn't need any of these.
Wow, that's great.
And so from a pain perspective, both of these operations actually end up doing, incredibly well from a pain control standpoint. The actual limitations in motion and function are a little bit different. Like we said earlier, fusion operations, it's all about immobility. We want the patient locked down, so we have them in a collar for several weeks if it's a multi-level fusion. And I don't want them turning their neck. What I often tell my patients is, pretend like you're a robot. If you want to look right, I want you to move your whole body to the right. And then, and similarly in that way, because any type of shearing or translational movement is going to potentially reduce your risk reduce your risk of that fusion healing. Artificial disc is the complete opposite. As we said, it's a motion sparing operation. And so what you really want is for those people to retain that motion after surgery. You don't want them to get stiff. You don't want that bone to start healing and them to basically have the inadvertent opposite result of what you intended to from the beginning. So I tell them to start doing flexion extension exercises right out of the gate. I don't put my patients in a collar for artificial disc replacements, but I do for the first 6 weeks tell them that I want them to avoid heavy lifting, and that's because I basically want the disc to osteo integrate, and I want them to basically prevent spit out or migration of that disc. So that's more of an art form, but I in general say about 6 weeks of no heavy lifting.
Do you recommend high dosages of calcium after a procedure like that? To help with
Absolutely.
bone?
I at least think that you have to follow the WHO guidelines for daily vitamin D and calcium usage. I think that's very important, especially for our older patients, our older female patients specifically, but men as well. But we also do a preoperative evaluation, and that goes back to JP's question about, what goes into this whole orchestra leading up to surgery. So you want to make sure that if you have an osteoporotic patient or someone that's low in vitamin D or calcium, that you identify those people early and you supplement them before and after surgery.
I mean, that all sounds, it's amazing how much work goes into it. And just sitting here listening to everything that you were just saying, it's just like, I mean, it's not like production, but with production, there's so many things that go into play, and there's so many details that have to be, right, from like audio to lighting to, and I'm sure it's the same exact way before a spine surgery.
I think it's a lot more detailed.
If not more. Exactly.
There's a lot more staff with that one, I would hope.
I mean, do you consider yourself like an artist when it comes to spinal? I mean, when it just comes as your profession, do you consider yourself like an artist of your profession?
Yeah, I think that in a way we're somewhat carpenters in what we do, and the more attention to detail that you have, the more that's going to positively impact the results of your patient. I think once you start to treat everybody the same, you have kind of a playbook that you just follow on a routine basis, you lose the ability to troubleshoot, and your patients don't get that specific result, because in a lot of ways people are very different anatomically, and you have to kind of tailor your treatment plan to everybody specifically in that way.
Okay.
That's amazing.
I actually heard, and I read an article which I posted on our Instagram a year ago, is physicians who grew up in the 80s with video games are actually better surgeons than ones that grew up prior to video games. I have to look this up, and I'm going to try to link it on the bottom, but there's like a proven fact that
have you heard of anything like that?
I'm going to back that up.
Better because they're more detailed.
I did play some Halo in college, so
nice.
I think that definitely qualifies.
Nice.
All right, we're going to take it.
So we're going to be talking about robotic assisted spine surgery. This is a couple of articles that I basically read in the last couple of days about different types of robotic. I've heard there's like Da Vinci machines. I mean, these names are really cool. So these machines must be really, really expensive and must be hard to operate. Have you had any training for robotic surgery?
Yeah, absolutely. The Da Vinci, we see it more on the general surgery side. On the spine surgery side, we've been using the Mazor X and the Excelsius. And we really think that spine surgery with robotics is going to be somewhat of the future. I think a lot of the companies are making big investments into seeing that there's several iterations of robotics and machines that are going to continue and get better. Right now, we're kind of at the first early iterations in spine surgery with robotics as it stands right now.
Wow, that's great.
That's very cool.
That is very cool.
This is where we go back to the video game thing. Again, like hearing that surgeons do amazing jobs with robotics and generally like hand manual surgeries are 10 times better at it who played video games back in the day.
Yeah, and I feel like there's so many different things that are being created nowadays with robots, and it's like at our house I used to mop the floor and clean everything. Now we got a Roomba. We got a couple of Roombas actually, so that's actually really cool.
That's only because our son has an obsession with robots.
Yes, our son is gonna be some type of engineer, we believe. At least for now.
He takes them apart already, the little screws, puts them in a little cup, and puts back together the robot. So he might be the next, spine surgeon.
There we go.
That's actually what I want to talk about is what inspired you to become a spine surgeon? Do you have family history of it, or there's always a story? So I want to know this story.
Absolutely. It's a long story, but basically my brother and I are in medicine. We're the black sheep in our family. Everybody else is in real estate or finance or something like that. So Thanksgivings are uncomfortable at our house. But yeah, I mean, my family, extended family, was having difficulties with access to healthcare. They were in third world countries and this kind of stuff. So being a doctor and being able to really change someone's life from a young age, I always looked at those people as heroes. So I knew I was going to be a doctor at a very young age. And just the way that my mentality was and the way that I visualized fixing things, and then that having a direct correlation to patients' functional outcomes being improved. That always kind of had geared me towards surgery in general. I did live next to an ophthalmologist that I thought was just amazing, and so I thought initially I was going to be an ophthalmologist. But then I just found out that I just thought he was a really cool guy. I didn't like ophthalmology at all, and ended up seeing that orthopedics was really amazing. It really, you can have such an impact on a person's life just from a surgery. A hip replacement's a perfect example. Someone gets wheeled into your office, you do a hip replacement, and they're walking out of the surgery center or hospital the same day.
That must be so cool to see.
It's so rewarding, and you don't just impact their own function in their life, you impact their psyche, their sex life, their relationship with the people around them. I mean, it just completely shapes the trajectory of the rest of their life. So it's amazing.
So I guess you and your brother are the black sheep of the family. So my question is, you were talking about Thanksgiving dinner. So who actually gets to cut the turkey? Is it like a fight between you two? Because I would think so.
That's right. I still hold the title for that.
Oh, okay, good. All right. So where did you go to school? Where did you attend school?
Yeah. So I started out at a combined program. They don't do many of these anymore, but I basically was in a 6-year combined program where I grew up in Kentucky. Was there for a full ride. Really loved the state. But then I visited my brother at a track meet when he was running down in Atlanta at Emory in college, and just fell in love with the med school. So I canceled my automatic acceptance to med school in the 6-year program, and I left, and I went down to Atlanta early, and I just started down at Emory, and quickly became president of the class and loved my time down in Atlanta. And then from there, I fell in love with orthopedic surgery, and I thought I was going to be a sports surgeon at that time. And so I went down to Miami, and I was trying to spend some time with the Miami Heat and this kind of stuff, and ended up falling in love with spine surgery. Went back to Atlanta for a year, kind of trained with the top guys in the field. And then my family by that time had all relocated from Kentucky to Los Angeles, and here we are 1.5 years later.
Very cool.
So
you really quick, you touched on a subject. I know we already talked about, the different types of spine surgery and everything. Just really quick for the audience so that everybody knows, what are some of the effects that when you have a spine injury, what are some of the effects that, like the daily life effects of someone who has a spine injury? Like you said, sex drive, you said that things like that, it affects. What are some of the other common effects of people's lives after a spine injury?
We call them activities of daily living. I mean, it's really people's every action is affected in that regard. I mean, they say, I can't clean anymore. I'm a house cleaner. I can't after my son eats his dinner, I can't clean his plate. I can't drive my kids to soccer practice. I mean, every single aspect of your life can be affected by a spine injury. And then there's a very high rate of depression in patients with spine, pathology or disease. It just gets to a point where you're in this hopeless cycle, and cognitive therapy is actually a very big piece of the puzzle when we treat spinal patients in general.
Wow.
As far as that goes.
Wow, very interesting. Yeah, so
I think any person who becomes desperate enough with pain and suffering and not being able to move is like that anybody would be open to having a spine surgery. Pain is unbearable, so I can understand where people are definitely, after so many failed attempts with epidurals and everything, that they would definitely come and see you. So.
You're 100% right. 100%.
I guess any hobbies that you do
outside
tell
of
us
cutting.
a little bit about yourself and
besides turkey cutting.
I mean, an icebreaker. I play video games from time to time, if that helps.
Yeah. I'm more of an outdoors guy. I mean, especially in LA, you got to take advantage of the hiking scene out here.
Yes.
It's beautiful.
It is.
Especially from my time in Miami, we used to get really competitive in beach volleyball, so I play a lot of beach volleyball.
Very cool.
I used to do a lot of mixed martial arts and some kind of amateur cage fighting stuff. I hung that up a couple years ago because of my career, obviously, but those are a couple of the things that we used to do.
It's a lot of fun.
And some tennis on the weekends.
You see all the injuries that come from those kind of
Exactly.
You're like, I can't work on myself.
Exactly. I used to, I don't ski anything above a blue anymore. You just see so many bad injuries, and you got to kind of protect yourself, almost like you're an athlete or something like that. So.
Yeah, for sure.
I think being in your field too, you've seen so many injuries that happens to them, and it's like, okay, yeah, I don't want to be hobbling around, 10 years from now. So
Absolutely. And some of them are needless, injuries that didn't need to happen in the first place.
correct.
No, my goodness.
Well, thank you so much for coming on our show and teaching
Yeah,
us
we really
everything
appreciate you
about
being here. Yeah.
spine
Sure.
procedures. Again, everybody, this is Dr. Alexander Ghasem, and thank you so much for watching. And don't forget to like, subscribe, and what's the other part? Follow. Yeah.
Hey
We'll
guys,
do it again.
make sure you guys leave a couple comments if you have any generic or any type of questions that you want to ask the doctor. Please go ahead and comment below. I'm still gonna practice your last name. I feel like a fool for not being able to say it.
And again, don't forget to like, subscribe, and follow.
That's right, guys.
Thank
Have a
you
good
so
one.
much for
Thanks,
coming.
guys.
Absolutely.
Yeah,
Thanks for having
thank you.
me.
Thank you for coming.